Good day, everyone, and welcome to today's conference call, Primary Care Resilience WebEx number 5. Today's conference call is hosted by Jill Gillies. My name is Cheryl, and I'm your event manager. During the presentation, your lines will remain on listen only. If you require assistance at any time, please key star, then 0 on your telephone, and a coordinator will be happy to assist you. You may submit chat questions throughout this presentation by clicking on the speech bubble, type your questions, and click send to all panelists. These will be addressed throughout the presentation. I'd like to advise all parties this conference is being recorded for replay purposes, and I'd like to hand over to Jill. Please go ahead.
Okay, Cheryl, thank you very much, and good afternoon. As Cheryl says, my name is Jill Gillis, and I'm the portfolio lead for primary care and healthcare improvement Scotland, and delighted to welcome you all to this, our 5th WebEx in our primary care resilience series. And we're hosting these WebExes in collaboration with RCGP Scotland and the Scottish Government Primary Care Division. And the aims of our WebEx series are to reflect on what we've learned from our response to COVID-19, explore what changes we have made and what we need to make as we move forward, and connect and learn from each other whilst we're doing that. And so today's WebEx, we're going to focus on interface working across primary care. Next slide, please. This slide, I just wanted to share with you some of the feedback we've had on the evaluation from our last WebEx. Those of you who've joined previous WebExes will know that we do a wee evaluation at the end of each one, and really keen to make these meet the needs of all of our participants. So generally some really positive feedback, great webinar, short snappy presentations, just enough information, much work taking place across Scotland, and good to get, of course, to get some data in and around patients and types of consultations. That last WebEx was very much focused on long-term conditions, so that's what that feedback's in relation to. There was some even better risks. One of the comments we had was, sorry, but I feel there is a disconnect between the primary care coalface and his aspirations, and please don't apologise. It's really helpful, important feedback for us. We really do try and keep these as grounded as possible, and we hope that we've done that with today's agenda. So please do keep giving us that feedback. Next slide, please. This slide is just a reminder that we have a web page dedicated to this WebEx series, and you can access all the slides and the recordings from the previous 4 WebExes, along with the question and answers and all the resources that are shared through the presentations. We recognise that we get through a lot of information with a lot of presentations, and all of those are captured in that one dedicated web page. Next slide, please. Thank you. So many of you have participated in the sessions over the summer with Health and Social Care Partnerships and the BMA in exploring primary care next steps in a COVID world. And those workshops culminated in the report, Is Primary Care the Canary in the Coal Mine of our Health and Social Care System? And this report explores some of the enablers and barriers to interface working during COVID-19 and highlights some of the good progress. In today's session, we want to explore that further. Next slide, please. And this slide here, we've adapted this wheel from a King's Fund document, Community Health Services Explained, and it's highlighting the interfaces within health and social care, and it's definitely well worth reading, and there is the link, and we'll share that link with you after this. And you can see from the sort of where we've highlighted that where we've covered in a number of WebExes the interface connections, and today we're going to focus on secondary acute care and urgent care. And for our first session, I'm delighted to hand over to Dr. Michelle Watt, the Senior Medical Officer in the Scottish Government Primary Care Division, and Michelle's going to facilitate our first discussion. So Michelle.
Hi everybody, thank you Jill, and welcome to what's going to be another really busy day. And I'm really keen to get lots of chat going in the chat box, lots of questions please, and we can facilitate as much of an interactive discussion as we possibly can. Interface working is something that we've all been passionate about and been working on for a good number of years, but the last few months have moved us into working in completely different ways with completely different challenges. And one of the silver linings for me personally has been the amount of new relationships and new connections and networks that I find as we've kind of moved through our response to this pandemic. And, today I think is another example of how interface working has never been more important. And we've got some fantastic speakers today to tell us about how things have been going from their part of the world. And for this section, I'd like to introduce Dr. Carrie Loonan, BE, who for some needs no introduction as our RCGP College Chair, and an absolute passionate advocate for whole system interface working that's real person-centred and not forgetting the importance of helping those who need help the most. And I'd also like to introduce after Carrie Dr. Les Renachevsky, who is an orthopaedic consultant who I met quite by chance during one of our interface conversations and read some of the work that he and his colleagues have been doing through the Modernising Patient programme, and we just really clicked. We had so many things in common as he talked passionately from an acute care perspective about person-centred care and realistic medicine and putting the patient at the heart of decision making. And there's some fantastic work coming out from LEC and the Modernising Patient Pathways team. So without further ado, I'm going to pass on to Carrie and let's hear more about it. And please keep those questions coming through the chat bar, everybody. Carrie.
Thank you so much, Michelle, and to the team at HIS for inviting me along to speak today about the potential for interface working to improve quality and safety of patient care. As Michelle was saying, I'm Carrie Loonan. I'm a GP in Edinburgh and I'm also chair of the Royal College of GPs in Scotland. Next slide, please. And next slide again. So we're all probably quite familiar with the definition of interface now because it's a concept that's been around for quite a while. But I like to think of it as this, the point at which two systems come together, be it primary and secondary care, in-hours and out-of-hours care, health and social care, or within primary care itself across the multiple interfaces of extended multidisciplinary teams. Next slide, please. And my interface personally goes back quite a long, my interest in interface goes back quite a long time. Over the years, I've worked as a clinical lead for anticipatory care planning. I've worked as a GP appraiser and have been involved in lots of significant event analysis discussions that involved interface themes. I've been the interface executive officer for the Royal College of GPs and also the co-founder of the Lothian Interface Group. Next slide, please. And I guess my interest in interface has largely been around trying to better understand and improve the patient and the clinician experience of journeys across complex systems. Next slide, please. So I guess the interfaces of care present a number of challenges. They are independently complex systems that don't always relate or communicate with each other well. They've got different IT systems, different ways of working, different priorities often, and often as well, importantly, different cultures, and lots of other things which mean ultimately that the interfaces of care are not always as good as they should or could be. Next slide, please. And I guess the reason that it matters that our interfaces are as good as they can be is that it's estimated that around 50% of medical errors occur at the interface and that 30% of these occur at the primary secondary care interface. Next slide, please. So not only are interfaces potential areas of error and risk for patients impacting on safety, but they also impact on the consistency of care, the efficiency of care, on the interprofessional relationships within the system and on patient experience. Next slide, please. So this is often the image that springs to mind for me when I think about how the NHS sometimes works or is invested in. If we only ever invest in improving small component cogs of the overall machine and don't bother so much about making sure that the oil is plentiful and high quality between these cogs, then we risk having an inefficient, unsafe machine that doesn't function well and can't improve. Interfaces are literally the oil in the machine. But they can feel quite nebulous, hard to define, hard for any one part of the system to take ownership of. But we do risk ignoring them at our peril. They are our collective responsibility to prioritise, understand and improve. Next slide, please. So thinking about our sources of intelligence around the interface and how we can better understand and improve it, there are many. There's not time to go into all these in detail today, but I've been particularly interested in the learning we've achieved from surveying boards, from undertaking a review of significant event analyses that highlighted interface issues, from speaking with established interface groups and boards, and from our cross-college working group. Next slide, please. And we've done a lot of work within RCGP Scotland over the last 8 years or so, as listed on this slide. More detail can be found on the web link at the bottom, and Elaine Turner, who will be speaking later, will go into more detail about one of the most important projects that we have undertaken, which is supporting every board in Scotland to establish a dedicated interface group. Next slide, please. But I've also been really interested in the learning around interface during COVID-19, and I was recently asked to present at a Scottish Government meeting to reflect on these 4 questions. What were our interfaces like pre-COVID? What have our approaches to interfaces been during COVID? What have been the learning and silver linings? And looking to the future, what should our priorities be? Next slide, please. So thinking about these 4 questions, because I thought that was a really useful stimulus for thought, we know that the interfaces pre-COVID were pretty variable. This is between primary and secondary care largely, and relationships were often stressed, disconnected and siloed. Next slide, please. But what we saw during COVID was this enormous collaborative approach with priority given to up and discussing solutions. This was facilitated, of course, by more virtual ways of working and a genuine commitment to a whole system approach at the start, with clinically led solution finding, and then there were lots of examples of interface working happening at both the local and the national level. Next slide, please. And we learned a lot. I think we've rediscovered the joy in many ways of interprofessional respect and support for each other and the power of having a collective clinical voice. And we've demonstrated that having better interfaces has meant safer healthcare for patients. And working together has allowed us to develop guidelines at both a local and a national level. Next slide, please. And where established interface groups existed pre-COVID, here are a couple of examples from Grampian and Lothian, they have demonstrated the enormous potential and value that these groups can bring to crisis management and to recovery planning. Next slide, please. So here are a few examples. In the board level groups, there have been specific work around managing the care of shielded patients in an equitable way and in safely reopening referral pathways, which have both been enormously valuable. At a national level, the Scottish Academy, representing all medical colleges in Scotland, has had improved interface working as a key priority area for the last few years, but this has been a particular focus of our work during the pandemic and in the creation of our guiding recovery principles, which you can see at this link. Next slide, please. And there's been a growing awareness within government, I think, about the value of dedicated interface. In a letter to boards over the summer from John Conahan, Interim Chief Exec for the NHS in Scotland, there was specific reference to the importance of interface groups as a means of supporting whole system recovery. Next slide, please. So what have our key recommendations been from all of this? Well, we would like to see the creation of formal, dedicated and resourced interface groups based on the newly written Joint Interface Principles agreed by the BMA and RCGP Scotland and endorsed by the Scottish Academy. We want to maximise the digital opportunities available to us with an investment in IT infrastructure and support, development of peer-to-peer clinical decision support pathways for all specialties in all boards to allow us quick access to our specialty colleagues, particularly when people are having to wait longer to be seen, and as we continue to try and avoid referral and admission wherever possible. We're also keen to realise the huge potential for three-way consulting options, and we want to see continued improvements in the way we share information to allow more consistent and safe care. Next slide, please. There are a number of interface resources I'd like to share with you, with links to them on the slide. We have a lot on an RCGP interface webpage, including a SOAR reflective template, which is our software for medical appraisal that we developed for work shadowing, accredited for use in medical appraisal as a quality improvement activity under the Working with Colleagues section. Walking in each other's shoes, work shadowing, is a very powerful and effective way about learning about the challenges that colleagues on the other side of the interface experience, how we support each other better, build better communication channels, and learn about local patient pathways. There's also a great PBSGL module on the primary-secondary care interface too. Next slide, please. So for me, a healthy, high-functioning interface can really only be achieved through building and sustaining good relationships. Stress systems fragment relationships unless these are specifically prioritised, so let's not forget the lessons we have learned during COVID-19. Next slide, please. Everything is so much cooler when you're part of a team. Thank you very much for listening. And I'd like to take the opportunity now to pass over to Lek from the Modernising Patient Pathways programme. Thank you.
Thank you very much. Thank you for inviting me to share what we've learned about redesign. Realistic medicine principles, as Michelle said, are crucial, treating patients as people as you and I would want to be treated. Next slide. And now, next slide. So how can we relieve anxiety and uncertainty, especially in these troubled times? Well, by clinicians following their best instincts and communicating directly with patients and each other. Next slide. For example, 10 years ago, we developed the virtual fracture clinic model at Glasgow Royal Infirmary. Many units adopted this process pre-COVID, but after lockdown, it's become the new normal in the UK. So traditionally, all 7,000 patients would have been seen within 2 to 3 days after injury. That's the column in red, when you or your nearest and dearest are in the greatest pain and at your most vulnerable. Simply by giving patients clinical information and triaging to the most appropriate pathway, over 60% of unnecessary attendances were avoided, with the remainder seen face-to-face at the right time by the right person. Next slide. Similarly, enhanced vetting is the most powerful tool in the elective process. Patients are triaged by a senior clinical decision maker to the optimal pathway at the first point of contact, resulting in a more efficient and effective use of clinical time, with unnecessary hospital visits greatly reduced. Next slide. Communication with patients and GPs is essential after the optimal pathway has been selected. A very inconvenient question is, why are patients traditionally kept in radio silence as far as clinical information is concerned for weeks, months, maybe even years now, until they're finally seen face-to-face? So focusing on the green opt-in pathway. Next slide. Standardized clinical information allows patients time to reflect, discuss with family and friends, and read the provided websites. Patients are then better informed, and the consent process is enhanced, as there's a cooling off period in the post-Montgomery world. Next slide. 3 years ago, we developed an opt-in system at Glasgow Royal, which has increasingly been adopted by other orthopaedic units and specialties in Scotland. Clinical information booklets for common conditions were sent to patients, providing advice and management options, including self-care. For example, a 7-page booklet for moderate to severe osteoarthritis of the knee. I just want to draw your attention to the accompanying letter stated, it's entirely your decision, you as a patient, when you access the orthopaedic service. So it's open-ended, no time limit. And in capital letters, there is no need to go to your GP to be re-referred back to the orthopaedic department. Just contact us directly, and the contact number is provided. Next slide. In our initial study, when 87% of 706 GP referrals for 5 common conditions was sent clinical information booklets with an invitation to opt in, 1/3 had not contacted the department after 2 years. Next slide. A survey of 150 patients in the study demonstrated that the vast majority were satisfied with the process and information provided, and there was no statistical difference between the different socioeconomic groups. Next slide. The 12-week new outpatient referral target focuses on the tip of the iceberg, but returns account for about 3 million appointments in Scotland per year. There's now no choice but to count the whole iceberg and acknowledge that many patients are just kept in the system with no added value. Next slide. All Scottish orthopaedic units have been discharging selected patients since March, explaining the patients now in charge. It's entirely their decision if and when to contact the orthopaedic service for that condition. Next slide. For example, in Scotland, we've applied discharge PIR to hip and knee replacement follow-up as arthroplasty is a cure in over 85% of patients, and routine surveillance of asymptomatic joints is unnecessary. The key challenge is, does a return appointment add value? Next slide. So in conclusion, COVID has provided us with a huge opportunity to improve simply by communicating effectively with patients and GPs to avoid duplication and waste. Thank you.
Thank you, Les. That was really interesting, and to you, Carrie, and some great comments coming in down through the chat box. So this is the bit where we all get to ask questions and have a say. So please keep the information coming in, because we can't bring you in and see your face and get you to speak, but please do chat in the chat box. So I think for me, certainly hearing from Carrie, some things that really struck were about interface working being the oil in the machine, and we all know when the machine is running smoothly, there is just nothing better. When it gets sticky, it's a real problem, and you cannot travel. And I really like, Carrie, what you said there. Better interfaces equals safer healthcare. Why would we not want to do more of that? What do participants think about having formal dedicated interface groups? Some queries in the chat box about, should we do more than just strongly recommending, and should we do something to mandate it? And if so, how do we make sure that we get people that are passionate and really genuinely want change, and we don't just have titles for the sake of it? I think that's really important. And I think the other thing that both speakers really drew upon was that importance of having good relationships, which is absolutely fundamental to everything. And Kate, I love your comments down the side, up in Benbecula and the weekly huddle, and the importance of bringing people together there. And one of the silver linings, now that we're used to it, is the ability to use Teams and Zoom and digital. And I know, we've all been in big Teams meetings where there's been 400 or 500 people, and you're really coming together collaboratively, listening and learning from each other. And I think that's been a really positive benefit, really, of the last few months, and something that's very much welcomed. Resources and how we can build and share. Nobody needs to start from the beginning, and so thank you, Carrie, for sharing those, and obviously they'll be available on our site after today's speech as well. I really liked, Lech, what you were talking about around enhanced vetting, and what came out really clearly from the work you've been doing is really how we involve the patient as a true partner. So instead of that old system, patient comes, sees the GP, a decision to refer is made, and off everything goes into the ether until the patient may or may not come back and tell you how things got on, or you eventually get an outpatient letter. And I think having the patient as a true partner and properly embodying the realistic medicine principles is important. And Ed Russell-Smith, I think you've summed it up beautifully shadow there. So the best interface working is when there's mutual understanding, and that opportunity for shadowing, I think is something that we absolutely should do. And a quick story, I have a colleague, and the traditional primary secondary care interface challenges, shall we say, we're going good and strong, and an offer to go and shadow, and it was reciprocated, and literally within a matter of weeks, because of those relationships, no doubt, things really began to motor and change began to happen, and it was owned, and it was all down to those relationships. So absolutely key and crucial. So PEDS and cardiology, lots of offers around coming in and sharing and shadowing, and thinking a little bit as well about what has COVID opened up in terms of other opportunities for shadowing, and really interesting to see areas like public health. So much of what we need to do going forward in the new post-COVID landscape is going to be around population integrated care, and really understanding the health needs of our local communities, and how we address the long-standing inequalities across so many of them. And I think the relationships with public health is something that I think we can only strengthen as time goes on. And I think increasingly, as we start to see social care and social work take on a much bigger role, lots of opportunities there. But I'm going to give this last part over to Carrie and to Lech. You've obviously had a chance to read down the side bar there. Is there anything that you guys would like to come in and reflect on, having heard each other and the comments from the chat group? So Carrie first.
Thanks, Michelle. There's lots of really interesting stuff on the chat, and I've just been typing some things in there as well. I think that you're right. The potential for better interface working between public health and primary care feels like a kind of a forgotten interface in many ways, but during the pandemic, of course, we've had a spotlight shone on how important it is to have really good population health. And of course, within primary care, we're on the front line at a micro level, helping people at an individual and community level, and at public health there at a macro national level. And there's so much scope for learning and supporting each other in the roles that we do. So I'm really interested in exploring that. And I've popped a couple of thoughts on the chat around the principles for setting up good groups within boards. I would love to see them mandatory, but I agree it's really important that the principles around them are right. So the right membership, the right culture, such, for example, coming up with solutions for one part of the interface that doesn't inadvertently impact negatively on the other part. It's very much a commitment to whole system working and providing a good culture and influencing wider teams in the health and social care system. So I will pass over to Lech. I won't speak too much longer. Thank you.
Yeah, I think in the comments box there was about virtual shadowing, and I think communication is the thing that is really missing, and all because there's only so many hours in a day. So then you would say, so the modern world does it often asynchronously. What do you mean? Well, it's you get information. When you have time, you sit down in front of your device and you answer that. So there's a time. And then you can ask somebody, you can think about it, and then you get back and get back to the person. And I think doctors are traditionally brought up that the bleep goes on nowadays, the mobile or whatever, and you've got to instantly do something. Somebody sends you something, and you've got to immediately address it. And in practice, of course, it gets put, and there's a huge pile of work. Whereas if you, and that's what we found with patients and with other staff, that if you have one point of contact, you get back to the person, you seek clarification, and that person then gets back to you. So if you use email, then there's a record of it, and there's no need for committees to agree formalized processes and special forms and all the rest of it, because we've got the tools. It's just simply to join it up. And Kate made a brilliant comment previously. She said, well, we had all the tools, we could have done it, but it was just too disruptive to pre-COVID to do anything about it. Well, COVID has brought in the disruption, and it's catalyzed so many things.
Yeah, I think that's a great comment, Lech, and I'd encourage us all to be disruptive innovators. And, you know, if change needs to start anywhere, it's with people like you on this call today, and what you can take back into your board and start to disrupt in the best possible way. But I think the most important thing is to do it with kindness and not forget the complexity and the strain that the system is working in. Doesn't mean change still can't happen, but we've got to do it in a way that's kind and considerate of each other. And today's presentation is showing why that's, you know, it benefits us all. So moving on to the second part of our talk, I'm going to hand over to Scott, who's going to introduce our next set of speakers and continue on the conversation. So over to you, Scott.
Cheers, Michelle. Thank you very much. Scott Jameson, the Executive Officer for Quality Improvement at RCGP Scotland. We continue to be pleased to co-host this with Scottish Government and HIS. And just to get us started on this section, we have two speakers on this half of the WebEx. First of all, Elaine, who's the Clinical Lead for Interface for RCGP Scotland, and Lorian Cameron-Ross, who's one of our she's the Clinical Director at Out of Hours in NHS Highland. Lorian is interestingly described herself as an aspiring Highland superhero. Premium crafts on the banks of Loch Ness. Lorian will take us to Highlands, and I look forward to her talk. But first of all, I'll hand straight over to Elaine, who's got the expertise from RCGP side on the interface and the work that she's been doing of late. Elaine, I'll hand over to you.
That's great. Thanks very much. Could I have the next slide, please? Hi. So I've been asked, and thanks for the invitation, to talk about the RCGP Interface Groups project, which has been running for the last couple of years. I've worked both as a GP and a specialty doctor in renal medicine, so I have experience of working in both primary and secondary care. Next slide, please. So what I'd like to talk about is just to give a quick overview of the project I've been involved in with some practical examples of good interface working, what support's available from our CGP in our discussions with different interface groups, the enablers and barriers, other areas where there's a lot of interface work going on, and the future. As has been alluded to, we're in the middle of a 3-year project where COVID has landed in the middle, and that's led to some disruption to our project, as you can imagine. Next slide, please. So I'd like to start, I'm not up in the Highlands, I live just by the River Forth, and I'm quite fascinated by all the crossings over the river, which I think can look like patients crossing from primary to secondary care. The slide on the left shows a rather wobbly ferry boat, which was used until 1935. And I think some patients, when they move from one part of our healthcare system to the other, feel a bit like that. They're in a slightly wobbly boat, not knowing if all the information that's needed is passing to the other side, perhaps when they're discharged from hospital or moving from a specialist team to back to their GP. The second picture shows a medieval bridge which has been standing for 500 years, and I think patients would feel much more secure moving from one part of the system to the other with a bridge with good foundations, and I think interface groups provide an opportunity to build those foundations. If you want to look at the background to patients' views about the interfaces of care, then Rod Sampson, who's a GP in Highland, has done a very good review paper on patients' perspectives, and a lot of them do express a lot of anxiety about how they feel moving about the system. Next slide, please. So Carrie has very much introduced our project. The foundations were laid by her as Executive Officer with Interface, and we were able to achieve funding for a 3-year project, which included myself and a project manager to support the development of interface groups within health boards with the aim of improving care. Next slide, please. So some of the examples we've seen, which Carrie has alluded to, in Grampian, we were very pleased to go along to the launch of their Reconnect event, where they have focused on improving relationships between primary and secondary care. And Reconnect involves setting up a system for enabling work shadowing between primary and secondary care clinicians with GPs spending time with consultants and consultants then spending time in primary care. They also piloted a project on small group learning, where the groups included both membership from primary and secondary care, and the outcome from that project is actually about to be published this week. Unfortunately, their project has also been in furlough during COVID, and they're looking to restart the project, but as has been alluded to, work shadowing is quite difficult just now. Dumfries and Galloway have a new interface group which is very enthusiastic and started before COVID, and they have become a sorting shop for all sorts of problems as a go-to group who can get things done. And they focused on communication, such as setting out a standard template for clinic letters with the information set in an orderly way to help GPs understand what's happened at a clinic and what might be necessary for them to do. They've also moved on to looking at discharge letters and have been involved in some of the work around COVID during lockdown. GGC have got very well-established groups, as have Lothian Health Board, and in these areas they have looked more at clarifying roles of who does what between primary and secondary care, looking at referral pathways and working to ensure that there's an orderly transfer of any workload between primary and secondary care. So there's, as you see, a lot of work going on. Next slide, please. So the project, we first undertook a scoping exercise to find out how many interface groups there were in Scotland. 9 health boards have a dedicated group. Forth Valley and the Borders have not standalone groups, and none of the island boards at the time of our survey had a standalone group. We developed a survey which could be sent out to clinicians, which we then analysed to ask clinicians about their views on interface working, and that gave us a very good feel of what was happening across Scotland. And we've developed support materials to help with the development of interface groups, and these are available on the RCGP website, and we'll send the link out after. We've also shared learning through newsletters and webinars, and we would like to be able to continue to offer support to interface groups and build a network that people can learn from each other. Our project will be ending at the end of March 2021, and because of COVID, we'll probably be just catching up with groups to find out how things have changed during the pandemic and what we can take forward. Next slide, please. So I'll just skip over the next 2 slides that I've put in really to give more detail about the outcome of the surveys which we undertook, which is covered in this slide, and the next one. Next slide, please. So from our survey, the activities which groups undertake can relate to communications, interface, working, clarifying roles and responsibilities, managing test results, methods of communication, patient safety, relationships. And different groups have had different priorities, and I don't think that matters. I think it's actually helpful that we've been able to learn from what different groups are doing and then share that information. And often if you start in one area, such as relationships, you move on to make changes throughout the system. Next slide, please. We found in talking with groups that the key enabler was support from health boards for the groups. If clinicians have protected time and they have administrative support, then they're much more likely to be long-standing. to have equal representation from primary and secondary care, and if possible to have membership including someone from IT and quality improvement. And this can very much help resolve issues which are taken to groups. It's important that the group has a clear position in the governance structure of a health board so that people understand its authority, and very much having enthusiastic membership with people who've got an interest in the interface and are good at making connections and networking. And I think just by making the interface someone's job rather than it being on the periphery of their vision, that change starts to happen. And that's very much been the feedback we've had from the different groups. Next slide, please. There's obviously a lot of interface work going on beyond the interface groups. RCGP already has an effective interface module, which is available on the website to help with specific pieces of work. Carrie's alluded to the joint principles statement referring to interface working. GP clusters in their external function have a remit for quality improvement, working with other agencies. And obviously around IT, realistic medicine, patient safety, and outpatients, there's a lot of opportunities to take forward interface work, and it's quite hard to join all of this up. Next slide, please. So looking to the future, we're currently rebuilding connections with interface groups to find out what's been happening in each health board during COVID. And we think it's very important to capture the changes and how clinicians are working more closely together and are consulting widely on that. We'll then be writing a report making recommendations for the future direction. And just to look again at the River Forth, the bridges, we need to build newer bridges more strongly, and if possible, make the interface disappear when that is possible through smarter working using technology. Thanks very much.
Lynn, straight on to Lorian.
Hello, good afternoon. Thank you. Yes, so I'm Lorian Cameron-Ross, and as Scott alluded, I have a slightly unusual personal interface in that I'm a clinical director who also runs a small distillery. So I'd like to set the scene for some of our challenges to be put into context in NHS Highland. Next slide, please. Next slide, please. So NHS Highland covers more than 40,000 square kilometres, and it's larger than the Netherlands. It hosts a population of over 320,000 patients. Now, a quarter of them live in our capital city, Inverness, but the rest are spread across the region, including 37 inhabited islands. And with our ageing population, we have 86 registered care homes. So in the out-of-hours period, there is a complex network of assets to support the communities. This map shows 31 out-of-hours bases, units, 12 community hospitals and 7 acute hospitals. We do have a single hub in Inverness to coordinate the community services for NHS Highland. They also do this for Western Isles, Shetland and Orkney. Next slide, please. It won't surprise you to read our list of challenges. Anyone who's travelled to the Highlands would have appreciated many of these, be it poor phone signal at an inconvenient time, or transport links making it trickier to get to your destination than you first anticipated. Next slide, please. We've almost as many models of out-of-hours services as we do bases. These range from 100% GP practice delivered to 100% health board delivered, and a variety of mixed economies in between. An out-of-hours base means different things depending on where you find yourself. You may find a GP covering A&E, out-of-hours and the COVID assessment centre in a well-resourced clinical facility with nursing, domestic and admin support. Or you may find a single advanced nurse practitioner with a car full of kit in a remote location based in a bed and breakfast. It won't have escaped you that our solutions listed here are locality-based where we need boots on the ground, and centralised where we can manage things remotely and would like to benefit from economies of scale. Next slide, please. When General McChrystal's US forces were struggling to get the upper hand against the Taliban, he came to the understanding of the importance of networking and allowing your troops to work as a team of teams. Our hub is critical to tracking where all our assets are at any given time and to ensure the transfer of information to relevant people. Our out-of-hours teams need to be plugged into their locality services and know how all the working parts can work to the best effect. They need to feel empowered and confident to make appropriate local decisions without waiting for centralised permission. This requires clarity of purpose and a culture of trust. These are the two things which sit at the front of my mind when trying to provide clinical direction. Next slide, please. Having seen many drab service models depicted over the years, I thought it would be nice to treat out-of-hours to something a bit classy. The cut of a diamond determines its brilliance. It's the facets that are key in allowing maximum light reflection. So in my mind, our facets are our interfaces, and by actively working to develop each one, we have a better chance of brilliance. Each interface deserves a bespoke approach. COVID may have thrown a spanner in the works for some of these, but it has amplified others. The plethora of online meetings this year has allowed out-of-hours in NHS Highland to raise its profile amongst our daytime peers. Recent examples of interface working include joint case reviews with Scottish Ambulance Service, echo teaching sessions with our mental health services, basics courses with pre-hospital emergency care clinicians, hospice staff shadowing in our out-of-hours bases, a palliative care helpline, and a professional-to-professional line that works out of our hub. The sharing of views and experiences is inevitable, and it's invaluable. Next slide, please. Our in-house interfaces are no less important. We try to encourage peer support and networking. We program continued professional development and use an online tool called Clinical Guardian, which allows peer-reviewed cases and constructive feedback to clinicians, services, and fora such as the Antimicrobial Drug Committee. We have regular opportunities to network formally and informally. Each locality has their own identity, but also has its place in the wider urgent care team. Where services are under particular strain, we're piloting a mid-shift virtual check-in between neighbouring services and the hub to improve collaborative working. Online networks now mean that no clinician is ever truly on their own, regardless of time or place. We even have our own Spotify playlist and regularly see small groups arranging hill walks or cycles to boost resilience and well-being in their localities. So, in conclusion, NHS Highland Urgent Care Service simply couldn't operate without paying continuous attention to our interfaces. Often when things go wrong, it's because they have been neglected. I'm hopeful that by continuing to build a team of teams, clarity of purpose, and a culture of trust, we will continue to improve a service that we're proud of. Thank you for listening. I'm now going to hand back to Scott.
Lauren, thank you so much. And I think you've gone on to show that through geography and through necessity that you've really had to work hard at those interfaces. And I like your example of lone working being a concept in the head more than it is in practice, isn't it? And I'm sure some of your nurses and even GPs who work on their own hopefully don't feel that they are working alone when you've set out such a widespread interface there. Just picking up on some of the chat, some really good discussions here about referral processes and pathways and how we feel that sometimes that patients are not within that, and even then our systems with secondary care. I was chatting, I think it was Ali and myself and Dan were just talking about the Sky Gateway system and how that feels very just one way almost sometimes, and highlighting, I think was it discussion, I'm going to lose my track of where that was. Clinical dialogue, Dan said. Clinical dialogue within Sky Gateway allows a more interactive discussion I think that was an excellent idea. It's not something I've got access to in Tayside, unfortunately. Can I just maybe go back to, I like the diamond as well, Michelle. I did spot, sorry, Lauren, that I couldn't find RCGP on there, but I did see SGPC who don't have out of hours remits, so that made me a little BDT here, but maybe we could do more there, because RCGP certainly considers itself a 24-hour organisation to represent GPs all the time. Can I go back to maybe Michelle and maybe some of our speakers in the first half, maybe Carrie? Carrie, you're an informed, disrupting factor who's kind as well. As you demit posts, which we're all very sad about, what would you like to say with regards to interface groups not being compulsory? How can we change this? With a minute to go, what would you like to say? You know, I think it should be compulsory as well. How can we make it compulsory? John Connon's shying away from it, not quite there. How can we push it over the hurdle? What can we do this last little bit? Because I really would like it more compulsory.
Thanks, Scott. Well, I think I'm completely on the same page with you there. And when we first put together the proposal for the interface group projects, we asked for it to be mandatory, and we asked for there to be funded acute leads and primary care leads in every group that was resourced adequately. Everybody had the time backfilled. It was included in job plans, and there was a kind of toolkit to help boards set up the groups. I understand there's always going to be a tension between making things mandatory and making things voluntary, and often if you have voluntary groups being established, they create a different culture from the outset. But I think we have waited quite a long time to see how well voluntary groups can work. And my reflections over the last few years where there are groups that are established is that often it's a group of dedicated, enthusiastic, passionate clinicians coming together largely in their own time to try and improve the interface in their local board area, and that is just not a sustainable model. So I think to make it a sustainable model, if we're saying now that we've recognised the value of interface working, particularly during a pandemic, that it's made care safer for patients and easier to recover services and spread workload more equitably, then I think we need to see a kind of recognition of that in saying, okay, let's make this happen. And that was part of the reason why we worked alongside the BMA to create a joint principles document to articulate what does good look like if you're looking to set up a board group, because otherwise we risk having lots and lots of variation across the country and people not being able to learn from the experiences of groups that have already established. We know that there is an attrition rate within the membership of these groups because people get tired and they get frustrated that the groups are not resourced and that they can't hand on work to dedicated subgroups. And I think really that can only be achieved if you have properly resourced mandatory structures that have funded clinical leads that report up the way and down the way to the people that they're representing. So that would be my ideal outcome for this project. Thanks, Scott.
I'll leave it with you then, Carrie. No, absolutely. And, you know, this is about interface improvement, and there's lots of things that look at interface, be that our GP sub colleagues and things like that, and our LMC, but interface improvement is absolutely key, and it's a different thing, isn't it? Jill, I'm going to hand back to yourself. That's been an amazing second half there. Really, thank you to my there. And I'll hand over to you, Jill, for the closing remarks and a few type wash-up for the end of the show. Thank you so much.
Okay, thank you. Just firstly, before I move into next steps, and can we move to the next slide, please? And the next again. So really just to take a minute to thank all of our presenters for taking the time out of their busy schedules to speak on our WebEx this afternoon, and to thank all of you for attending. We hope it has been of value, and as we normally do, we'll send out a follow-up email with the link to all of the resources that have been highlighted. There have been a wealth of resources highlighted in the WebEx, so we'll share the links to those, and also the evaluation, which you can access. I think it's in the chat box already, so you can access that. But before I bring us to a close this afternoon, I just wanted to take a few minutes to outline some of the improvement support we have within Healthcare Improvement Scotland at the moment. So next slide, please. So we have focused our kind of improvement support offered around the winter on 3 priority areas. We've reconvened our pharmacotherapy collaborative, but very much tailored that back to focusing on serial prescribing. And we're working with a number of health and social care partnerships and 47 practice teams to develop a national package to support serial prescribing. So I know a number of you are doing that, and there's a number of really good examples of good practice. GG&C, Tayside, Lanarkshire, etc. are already rolling that out. I think we're looking to see what's that national package, and then we'll support the implementation of that early in the new year. In relation to anticipatory care planning, we're sharing some of the good practice in and around having those conversations through our primary care learning system. We have made 1 or 2 updates to the Essential ACP tool, which was developed at the start of this pandemic, and we are working with NES Digital to develop an interactive PDF version of the EACP tool. So no changes to that tool, it's just a wee bit easier to use, and that will be available on our website from January. And we're hoping to focus one of our future WebExes on sharing some of the learning in and around anticipatory care planning in the new year. The third priority area for us is care navigation. And if you could maybe move to the next. Can you move to the next slide? Thank you. In relation to care navigation, we published our care navigation 10-step guide as part of the primary care communications toolkit, and we're hosting a series of workshops in the next couple of weeks to support the implementation of that. But in terms of the primary care communication toolkit, I was going to hand over to Fiona Duff, the Senior Advisor in the Primary Care Division in the Scottish Government, to give us a couple of minutes update on the public messaging.
Thanks, Jill. Fiona here. As Jill says, I'm an advisor to the Primary Care Directorate at the Scottish Government, and for the last few months I've been working on public messaging. So hopefully you've all seen the Primary Care Communication Toolkit that Jill has mentioned that went out at the beginning of November. In it, there was a number of resources, including links to the new NHS Informed Community Services page we've developed, which includes information for patients around how services are being provided and delivered now within general practice, optometry, dental and community pharmacy, and to try and explain to patients how those services are being provided in a different way, but they are very much open. And alongside that, there are videos, again, from general practice, pharmacy, dental and optom that you can show and you can use on your websites, on your Facebook pages, on your Twitter accounts. And a big thanks to Carrie, who you've heard today, who's the face of general practice on that video. And I know many of you are already using that on your practice websites and other places, so please keep using that. Alongside that, we're doing other work. We've just, hopefully some of you will have seen in your local papers over the last couple of weeks, adverts to promote utilisation of Pharmacy First scheme at the community pharmacy and to raise the public's awareness of that. And many of you will know that the redesign of urgent care work has launched today. So the plan is that hopefully within the next week we will send an update to the toolkit out to all GP practices, health boards, HSCP, professional bodies and others, with some additional resources that you can use to support your messaging to the public. So in that toolkit, there'll be some resources to support messaging around the redesign of urgent care and when patients should dial 111 rather, instead of going to A&E. Also in there will be some resources around the NHS 24 winter campaign. Many of you will be familiar with the Dr. Wiesel that has been used over many years. That's not what it's going to be this year. This year the name of the winter campaign is Show You Care, Prepare, and it's encouraging patients to make sure they've got all their medication, over-the-counter medication, etc., and they're prepared for winter. And again, it really promotes the utilisation of community pharmacy. So that will also be in the toolkit. And we are also pulling together some of the wellbeing and self-help support resources, such as the Clear Your Head campaign that has been developed by the Scottish Government to support patients with their mental health and wellbeing, and again share those resources with you as well. All of this is now available on the NHS 24 website, and we'll share the link for that as well. So hopefully keep an eye out on your emails, and that should be out in the next week. Thanks, Jill.
Thank you, Fiona. Next slide, please. So really mindful. We've given lots of information and on this website, on this WebEx. Sorry, this page here is outlining where on our website all of those sort of tools and resources are, particularly if you want to sign up to our care navigation workshops, which we're running over the next couple of weeks. As I said, we will send out a follow-up email with the links to all of the tools and resources that were discussed today. We recognise that this format and medium of running these WebExes is not necessarily the best, and we are going to look to transition in the new year onto Teams, and we hope that we'll be able to see you all in the new year. But for now, thank you very much for taking part in today's session, and have a good afternoon.
Thank you. So everyone, that concludes your conference call for today. You may now disconnect. Thank you for joining and have a very good day.
Your call is either in our queue or on hold at the moment. We will connect you shortly.